What's up, everybody? It's Mr. Johnson. I know that it's been a little bit weird with me gone, so I wanted to make sure that there were plenty of materials here for you so that you can be confident with where you're at with what we're learning. So we're going to start super fast, but just wanted to make sure that you guys kind of understood how this is going to work. This is pre-recorded. Obviously, I'm planning on doing a live video, at least one live video for every chapter on YouTube Live, which means that you'll be able to interact with me. So I'll host those, let you know what time I'm going to be opening things up, give you the URL so that you can go and see it, and then you can chat with me and send live questions so that you can ask for things to be clarified. And just so that I'm, making sure that you guys kind of understand my whole thought process, I felt like it was important to get my face on camera so that you guys can, we haven't really known each other for very long, so you guys can see me and you can kind of see what I'm doing. But if you've got other requests, if you've got things that you think would help you, just let me know, because I want you to be successful. So we're going to run through this. I'm going to give it the way that I normally would without the back and forth with all of you, and I'm going to do my very best to make sure that the points that tend to be the most confusing are what I focus on. And if you have questions after, then we can go ahead and we can hammer those out on an individual basis. So here we go. Chapter 13, no, it's already not working. Chapter 13 is all about vital signs. So we've already seen the topics, so let's jump right in. The vital signs, for all of you that don't know, are something that we measure on a patient that would indicate to us, hey, this person is at this level with the things that, for better or for worse, keep them alive. Their heart rate, their blood pressure, their their heart rate, their blood pressure, their respiratory rate. And for EMS, we have two more, which is skin signs and pupil response. Vital signs are just that. They're vital. And by vital, I mean they're critical. You can't skip them and say, I've done a patient assessment. It's impossible. Your patient assessment may not begin with vital signs, but it's not really complete until we get some. And yes, that even goes into the patients that don't have vital signs. So even if our patient is in cardiac arrest, they do still have vital signs that we need to assess. And even though they're going to be 0, 0, 0 for pulse, blood pressure, and respiratory rate, skin signs are probably going to be pale, cool, clammy, possibly cyanotic, gray mottled, the like, and pupil response is going to be absolutely nil. We do need to record them. So as it says here, these are major components that take a few minutes to complete. So right there and then, you already know this is not something that takes forever to do, but it is something that is, again, vital. Your patients that are receiving vital signs are just that. They must be patients. Here in Orange County, we have a very, very long definition of who is and is not a patient. But really, the easiest way to remember is if you look at the person and you say, this person may need my services, whether it be to do a checkup or to go as far as to treat and transport, I'm going to need to know where they're at. We need to assess what we call baseline vitals. These baseline vitals will help us determine what steps to take next. And these steps we call interventions. I've used that term in class before, but I want to make sure that this is abundantly clear. An intervention is any time that we intervene, we get involved, we go and we do something to help the patient, whether that be, something as simple as put a Band-Aid on a cut, or something as severe as intervene with chest compressions and electrical therapy for a patient in cardiac arrest. It'll also tell us where the patient is progressing, whether it's positive or negative, or maybe no change at all. And, as an added aside, it can also kind of tell us if things are progressing in a way that we would expect, or the patient's presentation is what we would expect, or if the vital signs don't match, that usually either indicates that either A, we haven't obtained them correctly, which is more often than not the issue, or B, this patient has all the signs and symptoms of a problem, but maybe what we consider to be asymptomatic or without symptoms. Your vital signs are going to be taken during the secondary assessment. I realize that right now that doesn't really hold a whole lot of water, so don't worry if you're like, the secondary assessment, where's that? The secondary assessment is by far our most integrated aspect of patient assessment. It takes the longest, and in some cases, we might only be able to do a very abbreviated secondary assessment because our time will be spent doing, typically life-saving maneuvers. So what are the vital signs? On our patients, again, in EMS, and everybody's a little bit different. What we might consider to be a vital sign may not be considered to be a vital sign in the emergency department. They would likely have a much larger list. And there are other vitals that we take, but they're not our core 5. So the core 5 are pulse, respiration, and I'm just reading it off in order here. Pulse, respiration, skin color, skin temperature, and skin condition. This is where we get into capillary refill, pupil response, and blood pressure. Now, it's a little bit difficult right now for you guys to kind of see. So what I would like to do is I'm going to use a tool here. This right here, blood pressure, very important. Pulse, obviously very important, and respiration. So in the grand scheme of things, when it comes down to it, these 3, pulse, respiration, and blood pressure, are the critical core vital signs, because changes in these, especially changes that are, negative, very, very high, very low, and of course absent, will tell us that, hey, this patient's probably not going to make it much longer without our intervention. It doesn't mean they're going to die. It just means that if we don't do anything, they will definitely probably die. Skin color, temperature, condition is definitely a vital sign that I think gets overlooked a lot, and I want to talk about that, and we will, but it's one that you can do as you arrive on scene. And pupils is one that we have, in the most recent years of the publication that we use, it's been much more of a focus. And that's really as a result of trying to figure out what's going on up here in the brain. We're looking for neurological response. Down here, there's a bullet point that says oxygen saturation is not a vital sign, but is often included with consideration of vital signs. And that is an excellent way for us to segue. Oxygen saturation, you guys are probably familiar with it because of COVID. One of the key early, vital signs that we were looking at in March 2020 and throughout the rest of 2020 was, what's their patient SpO2 or their oxygen saturation level. What that means is how much oxygen is in the blood. That is a critical thing to assess, but in EMS, it can actually lead us down the wrong path, and it can actually lead us to, in the best case scenario, maybe, do a little bit of a misdiagnosis or perhaps give an intervention like oxygen therapy that wouldn't necessarily be something that we need to do, or worst case scenario, might lead us down a path that can create a more, significant issue with our patient. Examples of that being, overloading a patient with oxygen because their SpO2 level is low, but the reason that they're low is because of an underlying medical condition, specifically something like COPD, emphysema, black lung, the, rare person with black lung, things like that. The other side would be if their SpO2 is very, very high, and we're talking like 100%, and it's because they've been exposed to carbon monoxide. And we'll get into that. So these 5, pulse, respiration, blood pressure, skin, and pupils, these are the 5 that we're going to be learning, but there are others that we need to consider. So now that we've got all that out of the way, let's jump in. Man, every time I think I'm going to be looking pro, I don't. Baseline vitals. Your baseline vitals are your first set that you obtain. So a baseline vital set would be whatever you get right off the bat. Baseline meaning this is right where we are. If it's any easier for you, most people look at a baseline as being, this is normal. Think in your own, in your own life as what your normal, mentality or outlook is. If you are a pretty easygoing person, they would say that your baseline is easygoing, very, very go with the flow. If you're a very, I guess, aggressive person or type A, you might be very particular and you always want to be in charge. The reason that that baseline is important is because if you're not acting like yourself, usually that means what? There's something wrong. So if you're not acting your normal type A self, or if you are normally very easygoing and laid back, and now all of a sudden you're super anxious, you're super angry, you're all out of sorts, we would consider that to be a deviation from the baseline. And that would usually indicate that there is some type of an issue. These patients that we're meeting, we don't know what their baseline is. So we need to establish it at that moment. After we get our first set of vitals, we're going to repeat vitals. The first set of vital signs should be your baseline. Your second set should, in theory, confirm what we've already got. It should be in the same ballpark. Blood pressure should be, within, anywhere between 2 to 10 points in either direction. Pulse, same. Respiratory rate really should be within, 2 to 3 respirations within the same range, a little bit higher or a little bit lower. And we know that if the second set of vitals doesn't match the first, it's either one of two things. Our patient is either rapidly deteriorating, or the vital signs that we got before may not be accurate. So we need to go back and check our work. The third set of vitals that we obtain, the third set, and it's not here in the slide, so please make sure that you write this down. The third set is what we would consider to be a trend. Once we have that third magic set of vitals, as long as everything looks like it is the same, and by the same, I mean the vital signs are very similar, or we can see that they're trending upwards, getting higher and higher, or lower and lower, we would consider that to be a trend. And when you think about it, it makes sense. If you do something, let's say that you want to start a trend, you want to be a brand new trendsetter, and you're like, you know what? Pockets, hate them, they suck. You cut all the pockets out of your pants, and you're like, I'm setting a trend. If you're the only person doing it, you're not setting a trend, you're just cutting the pockets off your pants. Now, if another person does it, that might just be imitation, and imitation's fine. But when you have a handful of people, a minimum of 3 doing the same thing, that's when we look at somebody and we say, hey, that's kind of trendy. Pockets, screw them, I hate it. So now that you understand the difference between a baseline set and your trending vitals, we're going to move forward and start talking about the actual vital signs themselves. The first is pulse. Your pulse is the pressure that we are able to palpate as the blood is pressed into the arteries from the heart. This can be found at the pulse points that we discussed in class, but we will review by placing 2 fingers gently over the surface of where that artery lies closest to the skin. Now, it's important that we note here, you are not able to take a pulse using your thumb. I don't care what anybody says. That's wrong. And I know that because our radial artery, and we're going to talk about these locations in a moment, our radial artery runs through our thumb. So we're going to end up having, and not through the thumb, it's not the terminus, but you guys get the idea. We can actually possibly interpret our own pulse as being an aspect of what our patient is having. So using your thumb as a finger that we use to assess a pulse when we're palpating, or using our hands or fingers to feel, is going to give you an inaccurate result. So rule of thumb, don't use your thumb. Cool, super easy to remember. 2 fingers directly over. This is going to give us our pulse. And another really quick important point, we don't need to press down. That's silly. We're not trying to stop blood flow. We're just trying to kind of, feel it as it is flowing through. It makes sense when you think about it, but a lot of people tend to, when they start, put way too much pressure. So again, don't cut off blood flow, finger directly on top, and just a little bit of pressure, if anything. When we're looking at a patient's pulse, and this is where, if you're taking notes, it's important to start divvying this information up. So I would put in your notes, pulse, skin signs, blood pressure, pupils, blood pressure, pulse, respirations, skin signs, and pupils. And then we'll talk about them each individually. So I want you to put these bullet points down. So for pulse, you need to take into consideration rate and quality. Rate is how fast or how slow over the count of 1 whole minute. And we're not even going to do it over an entire minute because we're going to be shortening things up. We'll count over 30 seconds and multiply by 2, or we will go ahead and count over 15 seconds and multiply by 4. Good job, athletes. The other aspect of pulse is quality. And we're going to talk about that in just a moment as well. But quality really tells us, hey, this pulse feels like it is strong. This pulse feels like it is weak. This pulse feels like it is bounding. It's just like I can feel it, and it's super, super hard to, to the touch. I can feel it just really forcing blood through. And you'll get some other people that say things like, oh, the pulse, it feels thready. Find me someone that can explain the difference between weak and thready, and I'll go ahead and I'll give them an award. But weak and thready, they do tend to be of the same nature. Generally speaking, weak and thready are pretty much synonymous. So rate, how fast, how slow. So really the number. And quality, how does it feel? These are both things that we need to record. And when you get into patient documentation, you're going to notice that it's not enough to just write the number down. You have to write down the quality as well. So rate and quality. Everyone's got that. Fantastic. All right, so let's take a look at these gentlemen. We got this dude on the right with the bad haircut. Got this dude on the left with, I don't know, something that looks like my haircut, so we'll say another bad haircut. And you can see what he's doing. He's laying his fingers over the radial. Yes, the radial pulse point. The radial pulse point is super easy to find. It's one of the ones that we use like right off the bat anytime we're doing patient assessment, because it really should indicate to us that the patient has effective cardiac, it's got effective cardiac pressure, let's say. That's the dumbest way I've ever explained it, so bear with me. What we're trying to say is that the heart's able to effectively pump blood to the furthest aspects of the extremities. And more simply put, think of it like water pressure. If you've ever been in a house or in some type of a building that suffered from low water pressure, even temporarily, you know how frustrating that is. Water pressure and the pressure that our heart pumps blood out can be pretty easily compared, because low water pressure can, just like low heart blood pressure would indicate that there's a problem with the pump. And what's the pump at the end of the day, folks? That's right, nobody, it's your heart. So we'll start with the radial, then we'll move our way up. Pulse rate. And we're going to be talking about some numbers today. These are not all the numbers. We're going to focus on adults. I will give you a guide where we're going to fill these in for all of our age groups when we go through chapter 8. Chapter 8? I might be using the wrong chapter number, but it is the chapter on lifespan development. When we look at the majority of our patients in any regard, we're looking at adults, and these are considered to be universal numbers for EMS. So don't get hung up on other numbers. These really do kind of meet the standard across the board. So the pulse rate is how many times the heart beats per minute, or how many times it forces blood out of the heart into the arteries per minute. For adults, here's where you need to write this down. You ready? We got rate, we've got quality. These are the numbers. These are the hard, fast numbers that you need to memorize, because these are the ones that come up on the test, so don't forget. The normal heart rate for an adult, a healthy adult, is between 60 to 100 beats per minute, so long as they're at rest. Don't worry, we'll talk about it. Just relax. 60 to 100 beats per minute. Anything over 100 beats per minute is what we call tachycardia, or fast heart. Tachy means fast. Cardia means heart. Over 100 beats per minute is tachycardia, and it doesn't matter if it's 101 or 150, it's still called tachycardia. Bradycardia is anything below 60. Anything below 60. Doesn't matter if it's 59 or 30, it's bradycardic. Brady in this, in medicine means slow. Cardia, again, heart. So tachycardia above 100, bradycardia below 60. The healthy adult at rest should be between 60 to 100. All good? No one's putting their thumbs up because this is a pre-recorded video, so I'm just gonna move forward. If we have a patient whose heart is beating above 120 beats per minute, or they're fluctuating where we've got a patient that has 120 beats per minute that is extended, or 50 beats per minute that's extended, that's considered to be serious. Patients that call 911 are usually having an emergency. And we've said that, a million times in class. They're having the worst day of their life. So When we look at this patient having the worst day of their life, when they've called 911, they're probably not thinking to themselves, all right, well, called 911, I probably got time to, knock out some chores, or, maybe watch another episode of fill in the blank. No, they're sitting there waiting at the front door, on the front lawn, in the garage, in their place of business, on the side of the street, having a hard time. So it's not uncommon for us on our first set of vitals to show that the pulse rate is elevated between 100 to 140. They are, again, tachycardic. This becomes more of a problem when it is sustained. It means to us that their heart is beating faster, typically to compensate. But we will get further into that later on. On the other side of things, patients that have a low heart rate fall into one of two categories. They're either very sick or very healthy. Why would that be, Johnson? That doesn't make sense. Very sick and very healthy can have the same thing. Their heart rate is low. Well, let's talk about it for just a moment. If someone has a heart that is very well conditioned, it doesn't need to pump as fast, because every single time that it pumps, it's able to force out a large amount of blood, more than enough to get the body all of the oxygen, nutrients that it needs to survive. So if we're looking at someone that is an endurance athlete and their resting heart rate is in the 50s, is that still bradycardia? Yeah, it is still bradycardia, but it would be the kind of finding that we would say doesn't match the patient's presentation or is expected because of their level of endurance and health. When that bradycardia becomes a problem is when the heart is, and this is a very gross generalization, so bear with me, the heart is so overtaxed and it has been working so hard that it is not able to continue pumping at an effective range. It's starting to fail. It's not just starting to fail, it is in failure. So the heart is no longer able to do it. If you've worked out to the point of failure, and some of you are like, yeah, work out to the point of failure. What's up? Come to the WOD. I get it. You're CrossFitters. We know. God forbid we call it a gym. Anyway, when you are looking at someone that has, been working out to the point of failure, that last rep, they can't get that all the way up, or they can barely get it there. And then bringing it back down is, a Herculean, effort itself. They have spotters. They are trying to get them to the point where the muscles say, absolutely not. I cannot go further. The heart in failure is just like that, and it's going to go slower and slower and slower and slower and slower. So go ahead and we'll move on. But I do want to do this. I know we normally say, think about it, we don't normally think about anything, but because I'm out of the classroom, we're going to do this. What normal situations might account for a heart rate that is outside of the normal range? And I think that at this point, we could probably pause the video and say about a million different things, whether it be anxiety or stress, fight or flight. It could be underlying cardiac conditions. It could be use of drugs or alcohol. It could be any number of different things. And I don't think that anyone would say anything wrong, because really our heart is one of the most critical aspects of our body outside of our brain, because the two need to play together. If we don't have enough blood going through the rest of the body, the brain dies. The brain dies, and the heart's not going to know to pump. So it's just a snake that eats its own tail, as we have talked about before. So when we look at someone's heart rate that's outside of the normal range, what I want for you to do is immediately say that is an abnormal finding. Right off the bat, it is an abnormal finding. Tachycardia, bradycardia, they are abnormal. So anything out of that 60 to 100 range is considered to be, we want to pay attention to it. If it improves, that is something that we would consider to be more likely induced on the high side with tachycardia, induced by the event, or with bradycardia might just be that our patient has an incredibly fit heart and they don't really need to pump like that to fix it. Makes sense? So we're going to note that it's going to be something that we consider to be an abnormal finding. And even if the abnormal finding doesn't, in the grand scheme of things mean a whole lot, it is something that we still need to document, because as we've said in class before, if you didn't write it down, it didn't happen. Yeah, that's right. Let's move on. So we talked about rate. Now let's talk about quality. There are two factors that determine pulse quality. The first is rhythm. And that's what's going to really give us the idea of, hey, how regular is this? So When we look at respirations, blood pressure, and right now, pulse, everything needs to be in sync. How many of you are musicians? Again, this is a pre-recorded video. I don't know how many people are raising their hands, but yeah, you know what? You guys understand one thing and one thing that is very, very specific and important. Rhythm is everything. You can't have music where everyone just, who knows? Why? Because that's terrible music. That's not even music. It's just people whacking, whacking drums and blowing horns and destroying guitars. That is not music. That is noise. In the same way, our heart is not going to work very well if it's just full of noise. As a matter of fact, there are very specific types of noise that can cause chest discomfort and ultimately some negative results. But there are some of these, bits of, let's call it cardiac noise, that are fatal. They're not survivable. And we'll talk about that more in CPR, and we'll reflect on that throughout class, because those fatal arrhythmias are one that we're actually pretty well equipped to at least attempt to fix with our automated external defibrillator, or AED. But at the end of the day, rhythm means one thing. It is how regular the heart rate is going. So musicians, how do you keep rhythm? Well, either you got it in your head. So I'm looking at all you drummers and bass players, and the rest. But for other people, it's maybe not as innate. So you need to depend on someone to keep the beat. Or if you're trying to record, you're using something that's known as a metronome. And a metronome is a digital device, and sometimes it's an analog device that will hit on the same beat every single time. You set it up so it will only hit on this beat. If you are interested why I'm talking like this and I'm still doing the beat, it's because I'm a drummer and I'm dumb. Ta-da. So rhythm is going to be important. Regular rhythm, it's boom, boom, boom. We're good. Irregular rhythm. How many of you have had to go to one of those elementary school music extravaganzas, or I don't know, a recital, and they show up and everyone, okay, 1, 2, 3, 4. Hot cross buns never sounded so bad. You're like, I don't know what hot cross buns are, but I'd rather have just about anything else. I'd rather eat rocks. Irregularity. When we don't have rhythm, the heart is in, at the very least, it's in some type of crisis. Is that crisis new? Is it chronic or long-term? We don't know yet. But we do need to note that any irregular heartbeat, bad. If you've ever had a feeling where it feels like your heart is fluttering or racing out of your chest, you might be able to attribute that back to a couple of different things. Most commonly, it's way too much caffeine, and that type of fluttering or feeling of the heart missing things, those are called heart palpitations. Don't get that confused. We palpate a pulse, but a palpitation is going to be errant beats that don't belong in there. So again, back to the music thing. If you've got a marching band, you've got bum, bum, ba, bum, 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 ba, bum, ba, bum. We're very regular, right? And then somebody comes in, they're like bum, bum, ba, bum, 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 bum. That is something that a patient will immediately feel. It's something that most of us, if not all of us, have experienced at one point in our life. And for some people, that's a very regular thing. In the event that it's new, it hasn't happened before, that usually is an indication that it's either A, a brand new cardiac issue, or B, it's an underlying effect of a serious cardiac issue. But nevertheless, if they're not regular, it's a problem, and we need to note it. The second factor about pulse quality is force. So force is something that we talked a little bit about earlier. We have blood that's being forced out of the heart into the arteries and then being sent through the rest of the body. The pulse should feel strong regardless of where we feel it. And we understand a little bit about pulse point locations, and we'll talk about those in the next few slides. But when we're looking at it, the further away from the heart, it should be, in theory, weaker. But if you're getting strong pulses from the furthest away, and we'll use the universal pulse point location. Everyone's had a pulse check, unless, I don't know, you grew up in a cabin in the woods with no water and no electricity. It's right here. It's on the radius. That should feel strong. And if that feels strong, hey, you know what? Our body is, and our heart is able to pump effectively to the furthest parts away from it, which are the extremities. And that says here, threading. I bring up thready because this is one that EMT students and paramedic students too, they tend to use, not understanding that there is a difference between weak and thready, or so I'm told. But really, it's one of those things that if you say during a ride along, you're likely to get a paramedic that's going to say, thready. Well, what's thready? So do yourself a favor, please. Don't use the word thready. Just as a pro tip, just say that it feels weak. Because if you say thready, that's something that you may not really have the qualification to say just yet. Because, I mean, shoot, I've been doing this for, 14, almost 15 years now. And if I say thready, I mean, I have a hard time really explaining what it is. So I think that weak is probably going to be the best way to describe it. So it is important to understand that these are phrases that you will encounter. But if you hear weak and thready, it's a little bit redundant. It basically means the same thing. Weak, thready, doesn't really have enough pressure to effectively get past your finger, which again, we are not pushing all the way down. I'm trying to make sure that my, there we go, you guys can kind of see it. My background, sorry, SpongeBob is kind of screwing me up here. We're not pressing it down to stop blood flow. We're just trying to place our fingers over the top so we can get kind of an idea of how it feels. So we've already talked about it. The first one, radial. We use this in patients that are over the age of 1 all the way up to 125 or whatever. So patients over the age of 1, radial pulse, that's exactly where you go. It's located right here. It's on the inside of the wrist on the thumb side. And the easiest way that I've always taught is that the radius, this bone right here, is rad. See, thumb side, rad, radius, rad. You get it. Anyway, place the first 2 or 3 fingers on the thumb side of the wrist. Do not use your thumb. If anyone tells you otherwise, they're probably not a medical professional, so don't listen to them. It's crazy. Don't use your thumb. You can't do it. Don't do it. All right, moving on. In our patients that are under the age of 1, so like my little guy, Maverick, we would check a brachial pulse. A brachial pulse is going to be checked on patients over the age of 1, but the reason that we don't go for a radial is because their heart is very immature. And I don't mean like immature, like, oh, fart joke. No, it's immature as in it's not grown enough to really be palpated at the radius. So instead of going inside of the wrist on the thumb side, we're going to go on the inside of the elbow. We're going to go on the inside of the elbow. The radial pulse is very easy to locate. Anatomically, it is not going to be found somewhere different on patient A to patient B. It really does sit just outside of that radius of the radial bone, and that's going to be the distal head. And it's very easy to locate. Whereas the brachial pulse can be kind of all over the place. It could be a little bit higher up. It could be a little bit deeper. It could kind of be in the pocket. So don't be afraid to feel around a little bit. Sorry about the beeping. We use a dehumidifier here because my apartment is just as gross and sweaty as it is outside if we don't use it. So sorry for the beeping. Anyway, this is going to be our primary pulse location for patients under the age of 1. This is the only place that we're going to be checking on a patient that is under the age of 1 and responsive or unresponsive. So it doesn't matter. We go back one slide to the radial. We're using this on patients that are 1 year or older and they are conscious or showing signs of life. We'll get to that in a moment. So if your patient is up, moving, walking around, talking, responding, tracking you, at the very least showing signs of life, go for the radial. On these patients under the age of 1, we'll go for brachial regardless of how they appear. And then we got a little picture here of this little munchkin here, and you can see that the provider is placing their fingers where that patient's brachial artery is located. Remember, it's not going to be up all the way on the on the inside of the bicep there. Sorry, I'm absolutely losing all of my knowledge of medical terminology. It's Labor Day, and I'm not here to labor. So that's where they were able to locate it. If it's further down inside of the elbow, that's fine too. Wherever you can feel it, it should be something that's easy to palpate. Now, these two are known as peripheral pulse locations or peripheral pulse points. Peripheral pulse points are going to be found on the extremities. They're going to be found on the extremities, and they're going to be found much further away from the trunk. Our trunk is our chest, our abdomen, what everything's kind of attached to. Think of it like the big fleshy version of Mr. Potato Head, no arms, no legs, just the potato. So we need to make sure that we have peripheral pulses on our patients that are awake, conscious, alert, doing all that good stuff, because that's normal for them. They should have that ready to rock. If our patient is not showing signs of life, if they're not looking like they're alive at all, we're not going to be looking for a peripheral pulse. We are going to be looking for a central pulse. Central pulses start with the carotid. So the carotid is going to be on either side of the neck, and really it's going to be on the outside aspect of the trachea. And if we're trying to assess it, we don't need to use a whole lot of pressure, really no pressure at all. That is what we'll use if our patient is not showing signs of life and they're over the age of 1. Now, if you're wondering why we wouldn't use this on an infant, I'm going to tell you right now, if you cut off blood supply, even incidentally trying to check for a pulse on a little kid, and they have anything left going to the brain, you're absolutely doing the wrong thing. Check the brachial artery. That's really where you want to go. But on our adults, because they have a more mature system, a more mature cardiovascular system, they're not going to be in danger if you place your fingers gently on the outside of the trachea so that you can assess their carotid pulse. And we've talked about this a little bit in class, but think about this for a minute. If you go in to check someone's carotid pulse, should you be on the side that's closest to you, or let's say that my hand was over here? What looks worse? This? Look at me. Look at SpongeBob in the top right corner, or like this. This looks worse. It looks like you're choking your patient out. Don't do this. Keep it closest to you. So if you're on their right side, this is my right hand, then you would check on their right side. If you're on their left side, check on their left side. If you're on the right, don't check the left. If you're on the left, don't check the right. I think that makes sense. But if you're not sure, go ahead and check on yourself, and with their permission, because consent is everything in medicine, go to your partner and say, hey, do you mind if I check your carotid artery, and try it in the ways that we said? And then I think it should click. If it doesn't click, you might be, a serial killer. If that's the case, go ahead and shoot me. I'm joking. We're going to check on the side closest to us. There's another location for a central artery that we will use in specific patients, especially patients that have sustained trauma. We'll talk about it more in class, especially when I return and we're going through trauma as a collective unit, but it's known as the femoral artery. Now, a lot of people say, oh, the femoral artery, it's a huge artery and you can just get in there. Yeah, but it's located in a bit of a complicated location. It's in the crease, if you will, in between the groin and the upper inner part of the thigh. Now, I don't know about any of you, but that sounds like a pretty sensitive area. And if you've ever had anyone check your femoral pulse, congratulations, you probably survived a significantly traumatic event. No, you have survived it because you're in class, you're not dead. Yeah, that math checks out. So the femoral artery is not one that we're going to be using unless it is absolutely critical. It's very specific to trauma. So let's focus only on the carotid artery for patients that are not showing signs of life. Again, that are over the age of how old? 1. This is harder to do than I thought with the fake background. 1. All right. So how do we assess pulse? Super easy, super simple. You're going to count how many pulsations or how many lub-dubs, because we talked about lub-dub in class, over 30 seconds, and multiply by 2. Now, little hint, little pro tip, little hack. Can you count over 15 seconds and multiply by 4? You sure can, nobody. You sure can. However, if your patient's pulse does not feel regular, if the rhythm or rate or force does not feel normal, you shouldn't do it by 15 because we're getting a very small snapshot. So this is 15 seconds, this is 30, and then this is the full minute. If you're trying to figure out why that's so important, it's because we have more data to use to determine the general health of our patient. And if their heart rate is abnormal, too fast, too slow, if the rhythm is irregular, or if force is not, what we would expect it to be, it's very weak, it's very hard to palpate, that can indicate a larger problem. And that would indicate that we need a larger scope of information. Now, in the real world, because we like to do this in the aspect of, I want you to pass the national, so we need to talk about the national registry standard. So the national registry standard would be counting over 30 seconds and multiplying by 2. If it's irregular, you would count over a full 60 seconds. But I also want to prepare you for the real world. In the real world, we're looking for you to start with 30 seconds and then eventually graduate to 15 seconds. If you go through all of your ride-alongs and you only count over 30 seconds and multiply by 2, that's fine. Good for you. You will really not be asked to do a full 1-minute count of a pulse, because we have machines to do that for us. It's a cardiac monitor. And if they're having a heart issue, that's an ALS or advanced life support call, where paramedics are going to need to be sent out, and they're going to need to put them on a cardiac monitor so that we can see what the electrical rhythm looks like. Hey, buddy, why are you coughing? No coughing. So at the end of the day, we're assessing pulse by rate, rhythm, and force. And in all of our normal or close to normal patients will go, and by that I mean they're generally healthy, we're going to go over 30 seconds and multiply by 2. But if we're not seeing rate, rhythm, and force being normal, go ahead and count it over 60. Moving forward to respiration. Respiration is the act of breathing in and out. And I like to read that off the slide because it really is true. Respiration is the act of moving air in and out, right? No. The slide here isn't wrong. It's just half right. So how can we make this a little bit more effective? How can we make this a little bit more functionally correct? We'll go ahead and we'll change out respiration with ventilation. So I'm going to go ahead and I'm going to annotate here. I'm going to draw, instead of respiration, instead of that, we're not going to say respiration. We're going to say ventilation. Okay, so instead of respiration, we're going to say ventilation. Ventilation is the act of moving air in and out of the lungs. Ventilation is air moving in and out of the lungs. All good? Air in and out. Do it right now. Take a deep breath in. Deep breath out. That's ventilation. Respiration, without getting too crazy, is not air in and out. It's where we exchange gases, but we will get to that in our chapter on respiration, ventilation, and emergency respiration and ventilation. With respiratory rate, we're checking rates and we're checking quality. So rate and quality. That's an interesting slide. I'm sorry, that's out of order. Respiration rate. So the respiration rate is how many breaths the patient takes over 1 minute or 60 seconds. The rate will be either normal, rapid, or slow. And we're going to get some real technical terms here. So instead of rapid, I'm going to annotate again, and I'm actually going to change this to a different color. So instead of rapid, we're going to go ahead and we're going to go ahead and close that out. So instead, no, I wanted it to be all dark. Okay, whatever. So instead of rapid, we are going to say tachypnea or tachypnic. And so if it's really fast, we'd say that it's tachypnic, or we're showing signs of tachypnea. And instead of slow, we're going to go ahead and we're just going to do that. I'm going to go do this. I'm going to write it down here. We're going to say that it is bradypnea or bradypnea. Tachypnea means rapid breathing. Bradypnea, and I know that you're looking at it like, there's no way, it's bradypnea. Look, these are words where it's all about your emphasis on the syllable. Pause for comedic effect. All right, now that no one's laughing. What I'm saying is where you emphasize the different syllables, it'll sound different. So tachypnea is fast breathing. Braid apnea or bradypnea is slow breathing. Okay, you got us there, man. Thank you for giving us that whole lesson on emphasis on syllables. Give us the numbers, old man. You got it, nobody. Those numbers for an adult at rest is between 12, so that's a low end, to 20 breaths per minute. Anything below 12 would be, what is it? Say it with me. Bradyapneic. Very good. Bradyapneic or bradypneic. I don't even like saying it like that. If it's over 20 breaths per minute, we would call that what? Yes, tachypneic or tachypnea. Very good. High five. So bradyapneic, slow. Tachypneic, fast. Respiratory rate is one of the more difficult blood. It's one of the more difficult vital signs to effectively document because it's just kind of difficult, and it really does depend on the patient's age, their sex, their size, how physically fit they are, and even their emotional state. And if you're thinking to yourself, yeah, I kind of know what you mean by emotional state or physical conditioning or age or sex or size, it's because we all understand how it feels to breathe, in a way that is not labored. It doesn't take effort from us. And labor is usually induced for most of us by physical activity, but it can be induced by, faster breathing can be induced by emotional state. So when you get anxious, what happens? Yeah, our respiratory rate goes up. If we feel like we're calming down, what tends to happen with our respiratory rate? Well, our respiratory rate starts to fall, and not in a bad way. It just falls back into that, hopefully within that realm of 12 to 20 breaths per minute. Just like pulse, someone that has an incredibly conditioned body, especially with our endurance athletes, they may not need to breathe between 12 to 20 breaths per minute. They might actually have a respiratory rate that's below 12, but that's because that's normal for them. The patients that we're looking at where that is not effective are the patients that they're struggling to breathe, and it's as a result of injury or illness or something else that's underlying, and can be the difference between, we need to coach them a little bit, or we maybe need to supplement them with oxygen, which is a drug, or we may need to jump in and say, all right, dummy, you don't know how to breathe anymore. We're going to do it for you. We'll bust out that tool, we'll bust out that bag valve mask or BVM, and we'll ventilate them. And we have other devices that we can ventilate with as well. So we'll talk about that later on in class. So when we look at respiratory quality, we're going to put it into one of four categories. It's either normal, which, we've got good rate and good effort and good sounds. Something shallow. Shallow breathing is where they're not taking a full breath in. A full breath in is shallow, is more panting. Labored is where the breathing and the body language are very synonymous with one another. We know what labored breathing looks like. I know that every single one of my adult students climbing up that hill, and if anybody starts singing Kate Bush, I swear I'm going to freak out. So just, you're climbing up that hill. Sorry, I'm trying not to do it myself. And you get to the top and you're trying to have that conversation with your friend. You're like, yeah, man. Yeah. Man, EMT class is so far up this hill. You're trying to catch your breath because you have expended what you have, and it doesn't mean that you're out of shape. It just means that you're under a lot of physiologic stress. Finally, we have, outside of shallow, labored, those are both bad, we have noisy breathing. And noisy breathing is something that we'll actually be spending a little bit more time getting into in a different chapter. But this is where, when we listen to their breathing, we can hear something in there that does not sound like air moving in and out. Now, I know that every single person in the class right now can think of at least one type of noisy breathing. And I'm just going to say it right off the bat. It's wheezing. If you've ever heard someone wheezing, it might be because of allergies. It might be because of, hopefully not, but anaphylaxis. It might be because they're sick, but you've heard wheezing. It's no, that didn't sound like wheezing at all. My wife is looking at me like I'm a crazy person. But wheezing is where you've got really, really tight air passages, and it's obvious. And that type of noisy breathing is not normal. You would listen to that and you would know, hey, there's a problem. Other types of noisy breathing are a little less obvious, but we'll get into those later. And those are things like rawls or crackles, ronchi, and other types of noise along those lines. Now, when we look at respiratory rhythm, again, just like pulse, if it is not normal, again, that beat right there, the marching band goes on. If you've ever seen a marching band that isn't in rhythm, you didn't really see a marching band. You saw a bunch of kids whacking, a bunch of drums, blowing horns, and probably falling over one another. So when we have rhythm, it needs to be regular. That rhythm needs to be in sync. So if you have a patient whose respirations are irregular, so the rhythm is not normal, they're breathing something, anything like that, you're going to document it, even if they're conscious, but especially if they're unconscious. To count respirations, we're going to count them over 30 seconds and multiply by 2. If their respirations are abnormal, that's just like pulse, we're going to count that over how long? That's right, 60 seconds. And then we don't multiply at all. In respiratory, we need to note the rate. So how fast, how slow, the quality. So what it sounds like, does it sound clear? Does it sound like there's wheezing or stridor or ronchi or rawls or any of those fun things that we'll talk about later in class? And finally, is it regular? Is the rhythm regular? So speed or rate, quality, sound, and rhythm, which is versus. Yeah, cool. The next that we're going to talk about is skin signs. Now, we're going a little bit out of order. I apologize for that. I don't like doing it in this order, but the textbook tends to do it this way because these are the most digestible things we can talk about. What do you think they're going to say for last? Yeah, blood pressure, because that's the one that's the most difficult. So we'll humor the book. We will humor these PowerPoints, and we'll go in that order. The next thing that, excuse me, the next thing that we're going to look at is skin. We're going to be looking at color, temperature, and condition. And condition is very, very specific, kind of like color. So if anybody's over there, lighting their pitchforks like, oh, we're going to cancel Johnson because he said skin color, relax. Put your pitchforks down, extinguish your torches. I'll explain, please. So all of this is going to tell us how blood is circulating throughout the body, and to a lesser degree, possibly how the brain is sending out signals. So color, we're not looking at, I don't care what color your skin is, and we're talking about pigmentation. We're talking about the amount of apparent blood that's below the skin surface. So when we look at patients, we're trying to figure out, hey, do they look really pale? Like the blood is drained out of their face. A lot of people say, oh, wow, they just went white as a ghost, or they lost all the skin tone that they had. They became very pale. That can be an indication of cardiac compromise, and it can be an indication of a lot of other things, but that's usually the easiest thing that people understand when we talk about color. So let's talk about where to look first. The best place to assess skin color in adults is going to be in the nail beds, and that's also where we effectively look for capillary refill. They say inside of the cheek. No, we're not going to do that. We're not going to look at the patient and say, open your mouth, and then fish hook them. That's ridiculous. Or the inside of the lower eyelids. Folks, if you look at your skin, regardless of what your skin color is, you can look at different aspects of it and say, hey, I can probably get the best result here. The best result for patients in general is going to be the hands. So the inside of the hands, the palm of the hands, bottom of the feet, and typically areas that are going to indicate general oxygenation, like in the lips, in the cheeks, and in the face, kind of around the eyes and the nose. Areas where you might not be able to get it as effectively are going to be aspects of the skin that are more readily exposed to the sun, that are covered by clothing, or are generally more weathered. So top of the hands, arms, legs, anything that's covered by the clothing. So look at the face, look at the inside of the hands, at the bottom of the feet. That's really where I focus on adults. On infants and children, again, we're going to be focusing more on their hands and feet, and especially with infants, they change color in their face like that. There's a problem. That's where it is. And if you don't believe me, think of it the last time you saw an angry baby. What color did they turn? Exactly. Red, purple, angry, right? Think about it. The last time that somebody got really angry, especially little kids, they get so angry and they start balling up their fists. And my son's probably doing that right now because I'm talking too loud, and their face gets so bright red or dark red in some cases that you're like, oh man, they're really mad. They're upset. Now, in our patients that have darker skin pigment, we would typically look in the lips and nail beds, but like I said before, palms of the hands are an excellent place to look on any patient, regardless of the general pigmentation of their skin. But I have an excellent resource that was given to me by a colleague where they spent an entire book talking about different aspects of patient assessment for patients of color. And I think that it's an excellent resource. I'll share it in class. I'll have a desktop reference that you guys can read through. I don't have a book to give to all of you, but it's actually a really good read. And it was written by a brand new medical student. And I think it's a really neat thing because I didn't have that when I was in school. You just kind of had to learn on your own. So let's move past color and let's look, let's move past location. And let's talk about the actual different colors. Now, the actual colors themselves are going to be pale, cyanotic or bluish gray, flushed, which is red, that angry, and then finally jaundice. So let's talk about each. Pale is typically going to indicate that blood is not reaching the surface of the skin. In the easiest way to explain, our body has tools, compensatory mechanisms that allow it to say, all right, I don't necessarily have enough blood to get to all the important parts, the heart, the brain, the lungs, and of course the internal organs. So I'm going to have to start prioritizing what we want and what we don't want. One of the first things that goes will be the extremities, fingers, toes, up here, not really in the lips, but like the tip of the nose, usually in the cheeks. That's usually where you can find the lack of blood right off of that in adults. And that will be pale in comparison to their normal skin pigmentation. Again, in our darker patients, of a darker skin pigment, sorry, that sounded terrible. In our patients that have a darker skin pigmentation, we're going to be looking again in the hands and soles of the feet. And we can also look usually just in the face in general. Pale means blood's being moved away from the surface of the skin. As plainly as I can put it, it's being moved away and reprioritized elsewhere. What does that mean? Oh gosh, that can mean a couple different things. We don't have enough blood. The pump is not doing its job. The blood vessels or the pipes aren't doing their job. There's something that's going on with the brain that's making the heart and the vein, or the blood vessels and everything go haywire. It can mean a lot of different things, but it's the first step is to note their skin color. The next is cyanotic. If our patient has gone into that stage of pale and we don't fix it, the next more likely progression will be cyanosis. So cyanosis is that one you see in movies and TV and you hear about in CPR classes. It's that bluish tinge or bluish gray tinge. That's a really late finding. I think a lot of people have been conditioned that cyanosis is something that's going to pop up right away. I'm going to go ahead and I'm going to check with my medical expert. Is that an early finding or a late finding? It's a late finding. Yeah, she's nodding her head and agreeing with me. She's saying that it's my wife, the nurse. Cyanosis is not an early finding. That's a late finding. It means that the patient has been without oxygen for at least a longer period of time than it would take to become pale. Patients don't just boom become cyanotic. They go from pale to cyanosis. And in the event that they go straight to cyanosis, and that's being a rare case, that would be such an acute loss of blood to that area that it might indicate something more severe like asphyxiation, where they're being physically choked. And that's more likely to result in flushing or redness of the skin before cyanosis. So if you see a patient that's cyanotic, just know that they are in a bad place. Bad because they need oxygen, they need it now, and it might not just be oxygen as a drug. We might need to go even further and breathe for them because they're not doing it on their own to some degree in some of these patients. The third bullet point here is flush, like red. So the patient has a bunch of blood that is rushing towards the surface of the skin. Every single one of us has been flushed at some point, just like every single one of us has been pale at some point. I would say that it would be odd to say that every single one of us has been cyanotic. I don't think that that's a fair statement. But pale and red, or pale and flushed, are both things that we would absolutely expect to see in our own daily lives. When do we become flushed? Well, it can be a number of different things. We're embarrassed. We are working out and we are under a lot of physiologic stress. We're angry. We're doing something that causes blood to be shunted into those spaces, like lifting heavy objects, or we're straining. But flushing is where we have blood that is rushing to the surface of the skin. It's much more red than normal. Finally, we have jaundice. Now, jaundice is the most unique of all of these because it's yellow. And I don't mean yellow like, it's just a little bit yellow. We're talking, evidently yellow. Is it as severe as The Simpsons? No, but when you've seen someone that's jaundiced, you've seen something that you're going to look at and say, they don't look good. They don't look good. It is a yellow veneer that covers the majority of their body. We can see it in their pupils, and it indicates a couple different things we'll talk about later in class, but really it's not one of those things that's going to kill them outright. So it's not as bad as cyanosis. It's not as bad as being pale or flushed. It's usually something that's a little bit more long-term or chronic, and it can indicate that the patient is significantly or severely ill or injured, but not to the point where like they're going to become yellow all of a sudden. They're not going to go, full banana on you, and then you have to call the hospital and be like, they've gone full banana. Call Co-Banana. That's not how it works. I don't know what Co-Banana is. I just made that up. Last is going to be temperature. So we've talked about. Oh, I'm sorry. Next is going to be temperature. So we've talked about color. Now we're talking about temperature. Temperature is going to be measured by the back of the hand. And we're going to be noting if it is warm, which is normal, hot, cool, which is slightly below what you would expect. They're definitely cooler than you, or cold, which you'll feel them and say, ooh. And I think that we've all had an opportunity to feel what that normally feels like. Hot, think about the last time that you had a fever, or assess someone that was running a fever. You put your hand to their, you put your hand on their skin, and we use typically the back of our hand. You can feel, that feels pretty warm. Cool is more what you would expect to feel directly after a workout or directly after, hopping out of the pool and drying off. That's cool. Cold is where you've got, you fell asleep, you popped your feet out from under the covers, and then you wake up and you're like, oof, my feet are cold. Or possibly you suffer from anemia or poor blood flow to the extremities, and you're constantly complaining that your hands and feet are cold. Or maybe you're just overexposed. Cold is cold. Hot is hot. Where we get into the, all right, where are we, is the not so severe, the warm and cool. So if it feels drastically different than what you would expect, or drastically different than the temperature of your own skin, that's a significant finding. What do you guys all see that's wrong with this picture? I mean, all right, so let's run them out. First of all, terrible haircut. He's got the lunchbox, just straight igloo right up in the front. Second, those sideburns that just turn into a whole bunch of facial. Okay, we're not going to keep making fun of this clown. What we're going to talk about is what doesn't work here. What is the problem? I'll give you guys just a minute to tell the screen. I realize that this is very much so turning into, Nick Jr. It's that, it's this. Sorry. The problem is that this provider has taken their body substance isolation equipment, the glove, and they've removed it, and now they're putting it directly on the patient's skin. Are they going to get sick from that? Probably not. Could they? Yeah. What's the point of wearing gloves if we're not going to use them? That'd be like putting on gloves and then pulling off all the fingers so that I can feel better. And if you guys are like, who would do that? Trust me, you'll find someone in the field. They like to do that. They're usually medics. Now, quick note about peds. If our child is under the age of 6, we're going to evaluate capillary refill. This is actually very easy to do, and we can do this on adults too. Capillary refill is where we take the patient's finger and we press down just gently. It doesn't need to be super hard, but it needs to be enough that we change the color underneath the nail bed. So I'm going to ask you to stop taking notes, take a look at your own hand, and if you're wearing nail polish, I'll give you instructions in just a moment. If you're not wearing nail polish, take your fingers, squeeze on top of the nail bed, and release. You should see that the color returns under your nail beds in less than 2 seconds. And if you're sitting there going, all right, how am I going to time this? Less than 2 seconds is obvious, because delayed takes time, and you're going to look at it and say, oh, that took a long time. If you have nail polish on, or if, God forbid, there was there's some kind of an injury that would prevent it, you roll up and you're dealing with a traumatic fingernail injury where all their fingernails are ripped out. That sounds awful. We can go ahead and just flip, and we can use the pad of the finger. And we can also, do the top of the hand or the top of the foot release. Basically, what we're trying to do is we're trying to find an area that's not covered in muscle, adipose, or fat tissue, or anything else that's going to take longer to respond. So we're looking at the extremities, and we're going to be pressing down, and we're making sure that the blood returns in less than 2 seconds. Now, why are we using this on pediatrics? Well, peds patients can be a little bit more difficult to assess. And one of the things that would be a very early indicator that they are not meeting what their body needs is delayed cap refill. It's an early finding, but a significant and serious finding. Delayed cap refill, or anything over 2 seconds in a pediatric patient, that's the time when we need to turn and burn. We need to load and go and take the patient to the hospital, really, really quick. Because as we mentioned in class before, our compensatory mechanisms, the things that allow us to compensate when things are wrong, as adults, we tend to go down a more gradual path, whereas kids say, I'm fine, I'm not okay. And if there's any parents out there, and I know that there's a couple in my adult class, but this will be to the folks out there that have younger brothers and sisters as well. Think about little kids when it comes to, just being generally content on a long car trip. They're okay until they're not okay. Everything's fine. They're sitting in the back, they're on their iPad, everything's good. And then all of a sudden, I have to go to the bathroom now. Well, there's a bathroom in 5 minutes. No, I have to go to the bathroom now. I'm going to the bathroom right now. That's the general concept behind pediatrics. They're okay until they're not okay. So finding capillary refill on these pediatric patients can be a straight indicator on severity of illness, severity of injury. If it's delayed, they bad, go to hospital. Adults, it's a little bit different. It's a significant finding. It's a finding that we can definitely document, but it's not going to be, oh, hey, delayed cap refill. In adults, that might mean that their extremities are cold. It might mean that they have anemia or some other type of circulatory issue, but it can also mean that that circulatory issue is because of an injury or illness. So a little bit of a column A, column B. Column A being not a problem, column B being a problem, but still significant, noteworthy, documented. Whereas in kids, just column A, problem. Moving forward away from skins, we have pupils. Wait a minute. Wait. I'm doing this live. Am I missing some slides here? Okay, I'm going to go back here real quick. Color, we talked about. Temperature, we talked about. We didn't talk about condition. So when we talk about skin condition, we're talking about the general condition of the skin, whether it is dry, moist, wet. We're looking at the way that the skin presents. In a normal patient, in a patient that is healthy, their skin signs should be normal across the board. Normal being that it is normal skin tone, normal skin temperature, so normal, warm, and their skin condition would be dry, or would be what we'd expect it to normally. If the patient was working out, we would probably not expect it to be dry. We would expect it to be at the very least moist, or possibly if they've been sweating heavily, wet. These things are normal for people that are working out. It's not normal for patients that are not working out. And so anytime that we have a patient that is not presenting with skin condition that we would expect, they're extremely moist or wet when they've just been sitting on the couch, or they've been working out all day and they're dry as bone, these are significant findings. So note the condition as well. Sorry about that, folks. I don't know what happened to that slide. I definitely need to check. Moving forward to pupils. Pupils are the black center of the eye. And the best way to explain how a pupil works, it's basically like a camera. And I'm talking really about specifically old cameras. If you take the lens and you change it, if you were to twist it, it would get longer, shorter. That changes the telescope. But it's also going to take into consideration how much exposure you have to light. In a dim environment where there's very little light, your pupil is going to dilate. Why is it dilating? Very simple. It's trying to let in as much light as possible so that you can look around, see your environment, and determine what is going on. The pupil dilating in a dim environment is a normal response. On the opposite side of things, in a bright environment, your pupil will constrict. And when we're in that bright environment, we do two things. The pupil constricts on its own. It needs to constrict on its own. But we also tend to do what? We squint our eyes, or without the use of sunglasses, we shade our eyes. Why are we doing that? Well, our eyes are basically, they're basically cameras, and when they're overexposed, it can cause the image to be washed out or completely unregistered or unreadable by the brain. And not to mention the fact that it can also damage our eyes. So we have a very visceral response to too much light. We squint, we cover our eyes. In that same regard, in a dark environment, I don't know a single person that would ever squint in a dark environment. Their eyes would be wide open, their pupils would be completely dilated because they're trying to allow as much light in as possible. When we assess pupils, we are looking for size, equality, and reactivity. Size, equality, and reactivity. Now I'm going to go back to the annotate button here, and I'm going to put in some text. So what are we looking for? We are looking for PERL, P-E-R-L. What does that stand for? It stands for P, pupils. E, equal. Reactive. R is reactive. And L stands for light. So we're looking for PERL. And sometimes people will, they'll go ahead and put this in as P, whoops. I don't know how to do this without messing everything up. P, A, R, L, which stands for pupils equal and reactive to light. And then other people will put in PERLA. And for some reason they say pupils equal reactive to light. I don't know why they throw an A under there, but we're looking for PERL. So if you're looking at your patient's eyes, we are trying to assess to make sure that they are pearly, pupils equal, and reactive to light. Now, equal and reactive to light. That means that they're both the same, they're both the same diameter, and they both respond to light in the same way. When we shine a light into them, they should do what? Yeah, they should constrict. When we remove light, they should do what? Exactly, dilate. So when we're looking, we're checking for PERL, size, equality, reactivity. Before we do anything, we need to make sure that we're in an environment where we can actually assess. So if you're in the middle of a football field in the middle of the day, you're probably not going to be able to assess for pupils. Now, if you're thinking, oh no, what am I going to do? I can't assess for pupils. That's okay. We can find ways to do it. We can either cover the eyes, we can bring in other things to shade the environment, or if we're going to be transporting the patient, we can move them into a rolling office, aka the back of our ambulance. Move them into a position where they can be assessed. So we're going to note the baseline size. So we're not applying any light at this point. We want to see what they look like without any light. We'll cover one eye and then shine our pen light into their eye. Please use the pen light. Don't use the flashlight that's in the front of the ambulance. Don't use the mag light. Don't use the one, if you're going straight Batman and wearing all your tools on the tool belt, don't use your 9,000 lumen light in their eye and blind them forever. A pen light's a very specific device. It's a medical device. So use that pen light. You'll have plenty of them all over the ambulance. We'll go ahead, we'll shine it in. And I realize that on my end, I'm doing it the way I normally do it, but we'll again practice in class, and then we'll go ahead and cover that eye, go over to the other eye, shine the light in, remove the light, and then note the size, reactivity. We're going to note size, reactivity, and shape. Now, what you can see in this picture is that they're assessing the pupils using a pen light, and this pen light actually has a great gauge on the side that will say how many millimeters the pupil is. Now, it's a great gauge. Most of our patients are between 2 to 3 millimeters, or anywhere from 2 to 4 millimeters. 1 is very, very small. We would call that constricted or pinpoint. And all the way at the farther side at 6 or 7 or even 8, that would be completely dilated, or as we call it in the field, their pupils are blown out. Now, these can mean a couple different things, but we're going to be integrating pupil response later in class through almost every chapter through medical and trauma. So just stay tuned. Here are a couple different pictures that you can see, just an artist rendition of constricted pupils, dilated pupils, and unequal pupils. Now, an artist rendition is fine. This is just what it looks like, but I think that seeing the real thing is much better, which is why we're going to take a look at this. This is a patient that has unequal pupil size. So if we're looking here, remember, our patient is always on their side. So the anatomic position is from their perspective. So I'm circling with the mouse right now, and I will go ahead and I will use the mouse tool. We're looking at the right eye. The right eye is what? Constricted or dilated? Very good. The right eye is constricted. Now, if we go over to the left eye, right here, if this is constricted, then this has to be dilated. So, something to note. When we're looking at a patient with unequal pupils or less than responsive pupils, so they're sluggish to response, that's pretty much going to indicate to us that there is either A, a neurological injury, or B, we're looking at something that's affecting them from a drug or alcohol standpoint. Again, we're going to go into these more throughout class, but the pupils, you know, a lot of people say the eyes are the windows to the soul. In EMS, the pupils are the windows into what you've done before we've shown up, or, you know, how badly you're hurt. And it's not just about, you know, size and reactivity to light, it's also about shape. Believe it or not, significant enough injuries can actually change the shape of a pupil. And I've seen everything from a cat eye in an injury. So instead of having rounded, they're more of a diamond shape. So it kind of looks like this. And I've actually seen one patient with significant head trauma where the pupil looked like a teardrop. It actually shaped itself into a teardrop because of so much pressure on the optic nerve in the brain because of swelling. So super interesting. Those are really rare cases. More often than not, we're going to find that the pupils are either sluggish to respond to light, non-responsive to light, pinpoint, or dilated, and occasionally unequal. All right, now we're here at the granddaddy of them all, blood pressure. So I'm going to go ahead and I'm going to stop. I'm going to pause with the recording, and I'm going to stand up and stretch my legs and figure out if my son is sleeping or not. But we're going to go ahead and we're going to pause here, and I'll come right back. So if I look different when I come back, I don't know, I probably just got beat up during a diaper change or something. All right, welcome back. I realize that there's no cut, so it's probably not a break for you at all, but we got everything good. The hiccuping in the back is my son. We just did a diaper change, so my apologies in advance if you hear crying. So let's talk about blood pressure. What is blood pressure? Your blood pressure is the amount of force, and I'm going to read it directly off the slide here. It's the amount of force that is pushed against the walls of the blood vessels as the heart pumps blood through it. So what you're measuring is the amount of pressure that is exerted on the walls. There are two aspects of every blood pressure, the systolic and diastolic pressure. The systolic, or top number, is created when the heart contracts and forces blood into the arteries. I hate reading word for word off the PowerPoint, but it truly is the best way to describe it. Your blood pressure, the systolic blood pressure, is the amount of force that it takes to force blood into the vein, or I'm sorry, into the arteries from the heart and circulate throughout the rest of the body. So when we look at things, the systolic number is the top number, and then the diastolic is the amount of pressure that remains in the arteries when the heart is refilling itself. So the left ventricle is relaxing, it's allowing blood to flow back in. Now this happens, you know, anywhere from, like we said before, in a healthy adult, 60 to 100 times per minute, every single minute of your life. So this happens just an absolutely unbelievable amount of time over the course of an entire lifetime. And as we get older, we start to see this change. But you know, when we're looking at this from the perspective of EMTs, these are very, very important things to know. Now, of the two, people traditionally say that the systolic blood pressure, or the top number, is the number that is more, the number that we can use more. Now, that's not necessarily untrue, but it's not exactly the whole picture, because the systolic blood pressure, yes, it does measure how much force is being pressed up against the walls of the arteries as the heart contracts, as the blood is being pressed out. But that doesn't tell us enough about what's going on with the heart, with the blood pressure, with the pressure exerted on the inside of the blood vessels or of the blood itself. So really what we're looking at is our cardiovascular system in one vital sign. We're looking at our pump, or the heart, the pipes, or the blood vessels, and the blood itself, or the fluid. So pipe, pumps, and fluid. So diastolic is also important when we consider that we're looking at this pipe, pumps, and fluid machine. We need to understand how much, how much the pump is able to do. And that's why the diastolic is still an important number to obtain. So don't just look at the systolic and say, oh, it's this number. We need to be a bit more, specific about what we're measuring, and we need to be a lot more purposeful with how we use that information. So a systolic pressure is great. Having both is better. A normal blood pressure for a patient would be a systolic blood pressure that is no greater than 120. What it says here is mmHg, that is millimeters of mercury. And the diastolic should be no greater than, again, 80 millimeters of mercury. Now, a blood pressure of 120 over 80 has traditionally been considered perfect. They say here that no greater than 120 and no greater than 80 is the goal, but really we want to see it under 120 over 80 or under 120 over 80 to really meet the newest cardiovascular health standards of health. Now, when we look at blood pressure, this is the most difficult vital sign because it's not just enough to say, oh, hey, it's got to be within 60 to 100, like our pulse, or between 12 to 24 respiratory, or we're looking for very specific things in skin signs and pupils. We're looking at a range. So we're going to be talking about this throughout class, and it is something that's a bit more in depth than just saying good, bad, or otherwise. We need to take a look at the blood pressure and compare that to the patient based on their age, based on their health, and based on their complaints. So an example would be a patient with a blood pressure of 160 over 90. 160 over 90 definitely sounds like it's higher than 120 and higher than 80 on the diastolic, correct? Of course. Now, 160 over 90 is certainly no blood pressure to write home about, and no one in their right mind would say that that's healthy. But for some people, and really for a large amount of adults in the United States, as well as the rest of the world, that type of blood pressure would be normal. Although, in the medical world, we would call that hypertensive. Hypertension or hypertensive blood pressures are blood pressures where the systolic is above 120 and typically measured above 130 or 140, and a diastolic that's above 80. On the other side of things, a blood pressure like 90 over 50 or 90 over 40, that would be well below the systolic level that we'd want to see and the diastolic level. So what we would call that is hypotensive. This concept is something that does not lend itself well to learning just in one chapter. So we're going to be talking later on in class and throughout class about what constitutes a healthy blood pressure versus an unhealthy blood pressure, and how we kind of correlate that to the other way that the patient presents. And if you guys can hear the screaming in the other room, I'm sorry, apparently my son is unhappy, so we'll keep working through that. Changes in blood pressure, and this is the number, the systolic and diastolic, or their relation to one another. So if they're getting wider apart or closer together, further apart or closer together, can indicate a significant change. And that's why blood pressure is one of the most critical vital signs that we need to monitor throughout our time with the patient, from the moment that we start our secondary assessment, or even before if we've got other people that can, and then throughout the time that we're with them until we transfer care to an equal or higher level of medical care. Now, the way that we measure this is something that we've already done in class while I was still present, and we use what's known as a sphygmomanometer. I can't even say when I'm looking at it. Sphygmomanometer. Sphygmomanometer. It's a blood pressure cuff and a stethoscope. What we've already talked about today is palpation, where we use our fingers or our hands to feel around for a pulse. We've also talked about counting things that we observe. So things that we would observe would be respiration, skin signs, pupils. These are things that we observe. So palpation, observation. And then finally, we have where we're using our stethoscopes, we call that auscultation. Auscultation is a big word, and I'm actually going to put it over here. Where's my annotate button? Oh, buddy. Auscultate. Auscultate. Let's hope that I did that the right way. Auscultate, which is right here, is the term that we use when we are using a device, such as a stethoscope, to listen to our patient on their insides. And I know that that sounds like a very non-medical way of describing it, but that's really what we're doing. So when we auscultate a blood pressure, we are listening for the very first time that we hear that lub-dub, like we talked about in class, and the very last time that we hear that lub-dub. And that's what gets us our systolic blood pressure and our diastolic pressure. The very first thing that we hear, that is recorded as a systolic. The very last that we hear, that's the diastolic. So go ahead and close that out. There we go. Now, when we're using a sphygmomanometer and a stethoscope, oh man, I said it the right way, or a blood pressure cuff and a stethoscope, we're going to be using a cuff that is appropriately sized, covers about 2/3 of the upper arm, and in between, goes in between the elbow and shoulder. Now, that is the traditional type, and I can show you what that looks like right here. We also have other blood pressure cuffs, and they're going to be based on the patient. So on an adult that has a very large bicep, we would use a large adult. On a patient that has a very small upper arm or bicep, we would use a small adult or maybe even a pediatric cuff. And if you're thinking that a pediatric cuff or cuff meant for children is something we would never use on an adult, I'm here to tell you that we use it on our older patients, our geriatric patients, on a regular basis. As we get older, our muscles tend to waste away. It's called muscle atrophy. So it's not uncommon for us to use these on patients that at one point would have definitely qualified for a full-size adult or even a large adult cuff because there's simply no musculature there for us to wrap the cuff around. Using a wrong size cuff, I know that this is a bit of an aside, but I want to talk about it. Using a wrong size cuff can actually give you an incorrect blood pressure, which can give you incorrect vitals, which can actually give you an incorrect treatment modality or treatment plan. So we want to make sure that we're using the right size cuff. How do you know that you're not using the right size cuff? If it wraps way around and it feels like the cuff looks way too big, it's probably too big. If you're barely getting it around their upper arm, and when you start adding air, you can hear the Velcro pulling apart, it's probably too small. Now, aside from these, large adult, regular sized adult, small adult, pediatric, we even have infant cuffs. We also have a unique cuff known as a thigh cuff. And a thigh cuff is the biggest blood pressure cuff that we use, but it's a very specific device, and it's something that we would only use in the event that we were not able to get a blood pressure on a patient for a number of different reasons. And we're actually going to talk about that later in class. So I hate to be that guy that teases it and then doesn't talk about it, but we're not going to be talking about it today because it is a very, very specific vital sign acquisition device. So how do we measure blood pressure? Wrap the cuff around the patient's upper arm. Make sure that it's about 1 inch or a little bit higher above the crease of the elbow. And then we're going to make sure that it's wrapped around the entire arm. I'm going to go through this quickly because we've done this in class. Then we'll go ahead and we'll make sure that our stethoscope is appropriately placed. The diaphragm, the big circular aspect, is directly over the brachial pulse or in the medial anterior elbow, which is going to be on the inside of the elbow, which I know that you guys are probably looking right here, but it's the sheesh part of the elbow. Cool. You can see a picture of it here. And then, really a lot of these slides are ones that are best done in class. So I'm going to be cruising through these pretty quickly, but I'll at least touch on them, at least so that you can hear it and get my thoughts. So we'll inflate the cuff. The cuff itself in class, we've been practicing where we only inflate it to 160 millimeters of mercury. So that's basically at the 12 o'clock position on the gauge. Really, we should, if we're doing it to the absolute correct standard, we would inflate the gauge until it is 30 millimeters higher than when you last heard pulse sounds. Once we get to that 30 millimeters higher, we'll slowly remove air by giving just a tiny bit of a turn to that thumb screw that's on our bulb, and slowly release air, and then note the very first sound that you hear and record that as the systolic blood pressure. We're going to continue listening, and you're going to hear that. Every patient's going to have a different sounding pulse, and I know that sounds crazy, but some of them are going to be very, very, they're going to be very low volume. It's going to be almost like someone's just, it's going to be very, very hard to hear. whereas other patients are going to be loud and popping right in your ear. The reason that we practice vital signs every single day in class, regardless of if you're in high school or adult, that's when we're going to be using that tool set so that we can practice and train our ears to listen to actual blood pressures. And because everyone is so drastically different, I want you to feel comfortable. Once you get to the back of the ambulance, I mean, it's going to be a brand new world anyway, because you're now in the back of a moving vehicle, let alone the, presence of lights and sirens. Road noise itself makes it very difficult to hear blood pressures unless you have trained your ear to hear them in a normal environment. And one of the things we're going to be doing in class, like I do every single class, is we're going to introduce a little bit of road noise or some ambient noise to class and then turn the volume up a little bit more, to the point where you're taking vital signs in a moderately loud environment. And we're going to record those measurements. And again, this is, if you didn't write it down, it didn't happen. Make sure that you're writing down exactly what you hear. If we are unable to hear a blood pressure, we can perform what is known as blood pressure by palpation. Blood pressure by palpation is different. And the way that we're going to prepare it, because we've talked about palpation, observation, and auscultation, instead of using our stethoscopes, we're going to use our fingers. We're going to place the cuff in the normal position, so up in that upper arm area, directly over the bicep, and then you're going to place your finger where we would normally get a radial pulse, so on the inside of the wrist, on the thumb side. And hey, would we ever use our thumbs to take a blood pressure? No. 2 fingers, 3 fingers, Scout's honor, whatever. Inflate the cuff, inflate it to 30 millimeters above where you no longer feel a pulse, and then slowly let the air out. As you're doing that, you're going to note the very first pulse that you feel and then let the rest of the air out. The very first pulse that you feel is roughly, not exactly, but roughly the systolic blood pressure. So you'll go ahead and you'll record that, and it'll look a little bit like this. And I want to make sure that you guys see it. So I'm going to annotate on the board again, right over here. You would annotate your blood pressure to look like this. So let's say that it was it's a little elevated. It's 140, so it'd be 140 over P, or we could record it as 140 over PALP. 140 over P, 140 over PALP, and usually we do 140 over P, 140 over PALP. That's going to indicate that, our other providers, hey, we weren't able to get a full-blown blood pressure. And why were we not able to get it? Well, it could be a number of different reasons. The patient was screaming. We were going lights and sirens. My partner was driving like an absolute maniac. We took, we didn't take surface streets. We took sidewalks the whole way, or whatever the case may be. Maybe you're in a loud environment that's, normally loud, like a concert, or you're at a festival. Whatever the case may be, a palpated blood pressure is typically considered an incomplete or partial set of vitals. And we're going to need to, at the very least, attempt again to try to get a full set so that we can get a systolic and diastolic. But in the event that you only have by palpation, hey, you know what? Better than nothing. Absolutely better than nothing. So do that instead of saying, I can't get it. Make sense? And then make sure that you always record it like that. Another quick note, when we're getting a blood pressure, because I don't have a cuff in front of me right now with a actual dial, remember that we can only record these numbers as even numbers. They are evenly spaced by power of, and this is off the best of my, let's go back a couple slides here. If you look here, by power of 20. So directly here in the center, that's the calibration line. The first that we can hear is 20. That line with no number is 30, then 40, 50, 60, 70, 80, 90, 100. Those tiny little lines in between are twos. So 20, that first line would be 22, 24, 26, 28, and we get here 30. Now, some people say, well, why can't I record it as an odd number? Those are all even numbers. Why can't I record an odd one? It would mean that you would be able to differentiate between that tiny little space in between 2 and 4. So don't ever record a manual blood pressure with an odd number. You don't have the ability to really know that. The only time that you're ever going to see any of those things, and I'm just continuing to the slide so that we can get to where we were. The only time that we're, whoops, a little too far. The only time that we're going to see an odd number in a blood pressure is when it's taken by a machine. And before you get too upset, don't worry. That machine is, calibrated for that specific task. That's its whole job. That's its entire purpose. Insert Rick and Morty meme of what's my purpose? Oh my God. You guys get the idea. Quick note on P's. It is very difficult to get pediatric blood pressures on infants, and it says children younger than 3, but I can tell you that it's really difficult to get blood pressures on them, even older than that, 5, 6. 7 is about where I would say that I feel comfortable. 8 for dial, we can get a blood pressure on them. Because of the different, the difference that we have in vasculature, which is a big term that we've used before, but I want to remind you, vasculature is all the vessels, all the blood vessels in the body. Because the vasculature, because the cardiovascular system and the heart, the blood vessels, it's so immature, getting a blood pressure on a little kid not only is difficult, it's not really, it's not going to be as clinically important to our treatment. You're better off observing for the way that they look, for respiratory distress, the fact that they're unconscious, so on and so forth. And it says all of that directly here in that second bullet point, and it really is that. I will tell you this, adults, patients lie all the time. Dr. House said it best when he did his show. Dr. House, he was one, but you guys get the okay. So Dr. House said it best. All patients lie. To a degree, we all lie, and it's not because we're trying to be nefarious. It's certainly not because we're bad people, because we're embarrassed or, we really don't know how to articulate how we're feeling. Little kids, they really don't lie about how they're feeling. They give it away by the way that they present. So when you're looking at your pediatric patients, this is the first time you'll hear it. I'll say it again. I love going on a call on a pediatric patient and walking in and hearing screaming. I'd rather hear blood curdling screaming because it means that they're probably not, directly dying. Kids that are fussy, kids that are screaming, crying, doing any of those things. And then of course the kids that are smiling, but no one calls 911 because their kid's smiling unless they're, smiling and hovering over your bed with a knife like a horror movie or something. But nobody is ever going to call 911 because the kid is smiling, having a good time. They're calling because they're completely inconsolable, or they're screaming. They're very obviously hurt. For us as EMTs, as paramedics, we look at that and we say, thank God. Because it means that at that moment, they might be sick, they might be seriously sick, they might be seriously hurt, but they're compensating, which is great. A pediatric patient, when you arrive and they aren't screaming, they're just dull, listless. The medical term would be flaccid. They have flaccid muscle tone where they're just, and for us with a brand new baby boy, I can tell you what that looks like. That's when he's just finished feeding. I think some of you have heard the term, we call it milk drunk, where he's just laid out because he's tired. He's tired. It doesn't mean that he's sick at all. What it really means is that he is in a position where he just is, absolutely unconscious, to the world. On our patient that has been, we've been summoned to take a look at them by 911, that's a terrifying concept. Those kids need to go to the hospital right away. So what I'm trying to say here, pediatric note is, if they look sick, if they don't look normal, if they're not fussy, if they're not crying, if they're not angry, if they're not screaming, load and go, run, take them to the hospital, because there's not a whole lot that you can do if they start going down that downward slope, which again is really aggressive as opposed to our adults that slowly go down. Cool. So when we are looking at a blood pressure monitor, it's really just placing the cuff, making sure that it is doing its thing, and then recording what is popping up on the screen. So there's really not a whole lot there. Now we're going to talk about a couple things that are absolutely not considered to be vital signs, but they are things that we report on our patients normally. First of which is going to be temperature. I'm going to keep this very short, sweet, and to the point. We have a lot of different devices that we use to record patient temperature. The one that we use most often in the ambulance is a temporal scanner. Temporal scanners go across the forehead, are aimed directly at the forehead. You guys are familiar with it because of COVID, but these are external temperature monitors. They can be accurate. Sometimes they are not accurate. What I would say is that more often than not, it's going to be a baseline reading. So it's going to be kind of like our very first set of blood pressure, pulse, respiratory, skin signs, pupil response. To establish a trend, we're going to need something that is not external. We're going to need something that's internal. So when we look at temperature, we have a couple different ways that we can measure it. Now, every agency is different. I'm just going to speak from my own agency. We use only external temperature monitoring as of now, because there's really no need for anything that's more aggressive than that. But it kind of depends on what the case of the call is, what time of day it is, what their activity level is, their age, and where they're measured is going to tell us where their temperature really is located. Now, a lot of you have been to a doctor's office, and I'm sure that every single one of you, at least once in your life, had a temperature taken where it was a device that went under the tongue, and it was measured like that, and it looked like this. These types of devices are much more accurate than measuring temporal across the forehead or indirectly at the forehead, but they're still somewhat easy to screw up, to not get a true number on. So I hate to get gross, but we need to talk about it. The most accurate temperature is going to be the rectal temperature. That is what's known as a core temperature. So if we're getting a temperature orally or across the forehead, it is important to note in your paperwork where you got that. So make sure that you say oral, temporal, and if for some reason you're working for a service, and typically this is going to be like critical care transport or specialty care transport, so those are CCT and SCT transport, that's when you're going to be looking more at rectal temps, because rectal temp is pretty much considered the the clinical gold when it comes to getting a patient's actual temperature. And we can get pretty close to that with others. So going under the axilla, so under the armpits, and sometimes in the inguinal space or in the front. But that's neither here nor there, and certainly something that we'll talk about more when we go into preparing you for your clinical internships, working on the ambulance, and hopefully going into clinical space as an EMT student in the ER. All right, we're going to end up finishing with monitoring devices. So a couple of these devices, and we'll talk about these more in class. The first is oxygen saturation. This is the bane of my existence. I'm not going to mince words here. I think that SpO2 is one of the devices that it certainly has clinical purpose. It certainly is relevant, but as a device, it is the one that gets EMTs in more trouble than anything, because SpO2 can be unreliable. So what is oxygen saturation? It's also referred to as SpO2, and it stands for the ratio, or I'm sorry, it measures the ratio of the amount of oxygen that is in the blood. So what we're getting is a percentage, and what they're reading is how much blood is being carried on hemoglobin as it passes through a tiny laser. And I think that a lot of people hear that, they're like, blood laser? Blood laser? Sci-fi. It's not that special. It really is not that special. This is a pulse oximeter. The top number that you see here, the percentage with the SpO2 next to it, is 98%. An average patient, a healthy adult, should be between 95 to 100% SpO2 on room air. Room air means no oxygen, no breathing devices, just the regular atmospheric air that we breathe. By the way, if you're wondering what that number below it is, that's their heart rate. That is their estimated heart rate based off of this little device. Now, you're probably thinking to yourself, dude, this thing sounds sci-fi. It sounds super high speed. Why don't you like it? Well, I'm going to get into that. But before we get there, take a look at this. Pulse oximeters are certainly something that EMTs around the United States are eligible and able to use. It can be helpful with confirming other things, but you should never use a pulse oximeter to confirm what you're doing outright. Our patient interventions, our treatments should be based on blood pressure, pulse, respiratory rate or respirations, skin signs, pupil response, and the other things that we measure. SpO2 is one of those tools that we can look at and we can say, all right, cool. And the best way that we can describe it is, where we look at different tools for measurement. I think most people know that you have a device in your pocket that can measure things. It's your phone. Your phone, and we're talking about iPhones here, as we've talked about in class before. I have no idea how Android works. You have an app in your phone, and I'll pull it up real quick, that is called Measure. Measure. And when you open it up, it looks, well, I don't think it's going to pop up. It's going to just look like whatever it is. It can give you very rough measurements. You can look at a device, you can look at an object, and you can give a rough estimate of how long something is by basically drawing point to point. But if you wanted to, measure twice, cut once, make sure that you weren't cutting something based on what a free app on your phone measured, you would use what? Come on. you would end up using measuring tape or a ruler. You would use something that is a static device that can't be interrupted or interfered because of, bad lighting or something like that. You need to check with that manual stuff. So that's where blood pressure, pulse, respirations, skin signs, and pupil response come in. Those are things that can't be corrupted. Those are objective findings. A pulse oximeter will give you an objective finding, something that's not tainted by your opinion, but it can be tainted by things outside of your ability to, kind of, know if that's what's going on. We'll talk about that in a second. So these are the numbers that you need to look for. Normal, they say that normal is 96 to 100%. Mild hypoxia is 91 to 95%. Significant or moderate hypoxia is 86 to 90, and severe hypoxia is 85% or less. Sure, these are great numbers. These numbers are certainly something that you can use. And I will say that in some of the questions that we'll start preparing for your national with in November and December for the adults, and in April, May, and in April and May for the high school students, these are definitely things that we're going to be talking about because these come up as questions. However, you should not withhold oxygen based on your SpO2 findings. You should also not give oxygen based on your SpO2 findings. You should be giving oxygen or withholding oxygen based on the patient's presentation, their respiratory rate, their pulse, their blood pressure, things of that nature, and of course, what they're telling you. What they're telling you, like, I'm having a hard time breathing. That would be an excellent way for you to say, you're having a hard time breathing. Let's take a look at your respiratory rate. Oh, look at that. It's elevated and you're working harder to breathe than normal. We should probably give you oxygen. It sounds super easy when I explain it like that, but students tend to get hung up on things where they can't see it. So I'm going to, continue bringing in pictures and showing examples of patients that are in true respiratory distress. But I want you to look at someone the next time that you're at the gym. True respiratory distress can be observed in someone that's not having an emergency. You can observe it in someone that's exercising. We go into respiratory distress anytime that we do moderate to, I want to say severe. My brain is saying severe, but moderate to high levels of athletic training, because we are demanding that our body go to its limits. That doesn't mean that you're having an emergency, but it's very, very hard to hide when you're having a hard time breathing. So if someone is saying, hey, I'm having a hard time breathing, and they're saying it like this, yeah, I'm having a hard time breathing. Extra doubt. I don't believe that. That's not really meeting the smell test for me. So what I'm trying to say is we're going to be continuing to talk about this throughout all of our chapters about, assessing your patient based on the signs, the things that we can measure, and their symptoms, the things that they'll tell you. Now, if you really want to know why I hate this device, here we go. Boom. Your SpO2 monitor can be affected by shock, hypothermia, carbon monoxide poisoning, excessive movement, nail polish, anemia, hypovolemia. These are just a number of different things that can absolutely throw these devices off. Now, why are these things that we, would mention? It's because SpO2 monitors are not worthless devices. They just tend to be over relied upon when you have a patient that is saying, I'm having a hard time breathing. Can a patient say, I'm having a hard time breathing, and have an SpO2 that's good? And yeah, 100%. So what we're trying to get at is that patients need to be treated based on their presentation and the things that we can objectively measure. SpO2, not as objective. So move forward, blood glucose monitors. We're measuring the amount of glucose that's in the bloodstream. This is, and we'll talk about this more. I know we go a little bit out of order, but this is a critical component of day-to-day cellular operation. Need to have glucose, needs to be there. This can be used to determine why a patient is altered. It can be used for patients that have diabetic history or are likely suffering from some type of diabetic emergency. At the end of the day, blood glucose monitors are being used more and more by EMTs. Here in Orange County, we've been using them for the better part of 15 years. So they're nothing new to us, but in the National Registry sphere of influence, blood glucose monitors are relatively new to the game for EMTs. Paramedics have always used them, but for EMTs, it's a relatively new thing. So this is a blood glucose kit. You can see, and I'm going to, again, use annotate here. You can take a look. This is our Accu-Chek monitor, or one touch monitor. So this is a blood glucose monitor. These are our test strips. This is an alcohol prep pad or ETOH prep pad. And these are our one-time single-use lancets. The one thing that's missing here is, I mean, would I be the Band-Aid man if I said there's no Band-Aid in here? So we talked a little bit about these kits before. Just know that in our class, we're always going to stock them with lancets, alcohol prep pads, Band-Aids, not seen here, Band-Aids, our test strips, and then the monitor itself. So when we get a blood glucose measurement, it needs to be under the protocols we have. Now, we'll talk about local protocol for Orange County, but everybody's a little bit different. When you take a blood glucose in Orange County, it's for very specific reasons, and it doesn't necessarily mean that you need to have paramedics en route. When you take one in LA County, it's a little bit different. If you're going to take a blood pressure or blood sugar in LA County, you need to have paramedics en route. And when you go down to San Diego, it's very similar to Orange County. You don't necessarily need to have paramedics on the way. What it means is that where we work is extremely localized. If you're in the adult class and you're like, well, I'm going to go to Orange County, then great. We're going to be talking about Orange County pretty much exclusively because that's where our class is located. And same for the high school folks. If you're not going to be going off to college, you're going to be sticking around, working at a company like Falck or Doctors, you're going to be working in Orange County primarily, then we're going to be talking about how that all works. But if you're going to be going to LA County, San Diego County, or out of state, you need to know what your local protocols say, and that's where your field training really comes in. So a lot of people tend to be surprised when they finish the program and then they go out into the field and they say, hey, congratulations, let's go spend another 2 weeks in class learning how to do it the way we do it. EMT is not going to ever prepare you to be an EMT independently. It's going to give you the basic knowledge to go out and learn how to do it specifically the way that we do it at our individual agencies. I'll go ahead and clear this, close that, moving on. So this is one of those skills that is best prepared and practiced in person. I'll run through the steps very quickly, but this is not going to be something that I would expect you to sit down and memorize and listen to over and over and over. So when we're using a blood glucose meter, we're going to prepare the device, make sure that our strip is good to go, and check the strip bottle to make sure that they're not expired, and make sure that our lancet is prepped. Follow up by cleaning the patient's finger with alcohol. We'll use our lancet to lance the finger and draw a little bit of capillary blood out of the side of the finger, not on the pad, on the side. And then we'll apply the blood to the test strip. The blood glucose meter will then analyze and give us an answer. While it's doing that, we'll take our Band-Aid and place that on the finger that we just poked. And then we will go ahead and record our findings. So this has just recently changed, and I want to make sure that we talk about this. Formerly, the healthy range for blood glucose was 80 to 120. Now it is 70 to 110. So I'm going to go fix this a little bit here. 70 to, oh, can I erase stuff? No. All that I can do is I can draw. So it's 70 to 110. Okay. So normal level is 70 to 110. Below 70 is going to be hypoglycemic. Above 110 is not considered hyperglycemic, but as we start to approach 130, 140, 150, that's where we start to get into hyperglycemia. We're going to spend an entire chapter talking about this, so don't get too hung up on the numbers yet. Just write down that a healthy operating range is between 70 at the low end to 110 at the high end. And we're measuring the milligrams per deciliter. So Mg/DL, that's milligrams per deciliter. So we're checking how many milligrams of glucose per deciliter of blood, because we're only taking a very small amount. We're taking, something that would not be traditionally measurable with anything that we would normally use. We're talking about something that is far smaller than even a cubic centimeter or cc. It's very, very small. Another device that we have, moving away from blood glucose, is capnography. Now, capnography is something that is typically used pretty much entirely used by paramedics, nurses, doctors. but it is something that we want you to be familiar with. And, later on in class, we'll bring in a device to show you how capnography works. Capnography is measuring the amount of carbon dioxide, that we exhale in each breath. So as we breathe in, we're breathing in oxygen, nitrogen, all the atmospheric, gases that we get. Really what we want to get out of that is oxygen. During cellular respiration and during our normal respiratory cycle, we need to get out the waste products that all of that incurs. That primary waste product is carbon dioxide. So as we're breathing it out, we're expelling that waste product. So end-tidal carbon dioxide, or end-tidal CO2, is going to be measuring how much carbon dioxide we're breathing off. The normal levels that we're looking for are 35 to 45. If we fall below 35, it usually means that we're retaining, and that can mean a whole number of different things. If it's over 45, it means that we're typically blowing off too much. And clinically, these are things that EMTs would never really get into, but we will spend a little bit of time with it because I think that A, we have enough time to do it, just about, and B, it's a very cool thing to be able to understand as an EMT, because you'll never be asked as an EMT to understand how end-tidal CO2 works, at least not in our current makeup of who does what in the field. End-tidal CO2 is something that we are largely using more, and unlike SpO2, where it can be very easily fooled by little things, end-tidal CO2, you're getting A, live reading, and B, it is just about impossible to fool it. It can tell us what's going on inside of the body, a number of different things, whether it be, retention of carbon dioxide, or off-gassing or off-breathing too much carbon dioxide. It can tell us about the patient's general pH balance. Are they becoming more acidic or more basic? And it can tell us about, how the patient is progressing. So we'll talk about that more in class. I don't want to, sound like it's not that big of a deal. It is a big deal. It's just not something that EMTs are traditionally asked to monitor or to be trained on. So this is something that we can see through special nasal cannulas, or if we got the patient on a special device like an endotracheal tube, we put a device on the end of the endotracheal tube that measures it as we're breathing in and breathing out, and it can tell us special things like, hey, maybe we're bagging too forcefully or with far too much volume. Or if, for example, if we get a big rush because it is a live reading, it's not something that's delayed like SpO2. When we get a large rush of carbon dioxide in a patient that's been in cardiac arrest, it can be an indication of the patient regaining spontaneous circulation or regaining ROSC, return of spontaneous circulation. So they've got heartbeat back. So they're basically just dumping all that retained CO2. Now you can tell that I personally like capnography. I think that end-tidal CO2 waveform capnography, it's very, very cool. I'll probably do a video on it a little bit later, just as a side, nothing that you would ever need to know for your EMT. But I know that a lot of my students want to become paramedics, or they want to go into nursing, or they want to go the more clinical route, as pre-med. And I think the capnography is one of those things that's so neat to learn about that we'll probably end up doing another video. All right, so we're going to do what we never ever do in class, which is the chapter review. If you wonder why we never do the chapter review, there's a whole lot of teaching theory that shows that chapter reviews don't really reinforce anything. It's basically just wasting time. But we'll do it here because, well, you're not really a captive audience. You can log off whenever you want, but I would urge you to at least check out the last minute or so of the video. So here's a review. We definitely can get a lot of information about a patient's condition by taking a complete set of vitals, but really what this bullet point should say is that we need to get as many of these vital signs recorded as possible so that we can establish what we're doing, why we're doing it, and if what we're doing is being helpful, hurtful, or not really changing, not really moving the needle at all. The EMT must be familiar with normal ranges for pulse, respirations, and blood pressure in both adults and children. And like I said in class, we're going to be building out the charts, our vital sign cheat sheet, as we like to call it in class, for each age group in the lifespan development of adults, from neonates, brand new babies like my son who's crying right now, all the way to our late adulthood patients, which are 61 and older. We're only going to use our vital signs to treat our patients, right? No, we're going to use our vital signs to establish what may or may not be going on, try to validate what we've already seen or observed, or even what the patient has told us. So our observed signs versus their reported symptoms. Because remember, signs are objective, they're measurable. You know, if I came to you and I said, this is, you know, this is, I don't know, this is a Subway sandwich, this is, you know, a foot long, it is 12 inches. And you said, no, actually Subway sandwiches that foot longs are only 9 inches long. And, you know, I'd say, well, then I feel lied to, and Subway makes me more upset than normal. Those are two different things, but we can really easily settle that argument by taking out a, you know, a ruler, a measuring tape, and we can say, you know, it is 9 inches. I was lied to and I want my money back. Whereas a subjective statement is Subway makes great sandwiches. To which I would say Subway makes sandwiches of dubious quality like their tuna, which is not even genetically considered fish. Sorry, this wouldn't be a Johnson lecture without me just throwing in random jokes about things that I observe in my day-to-day life. What I'm trying to say is that objective statements are measurable, subjective statements are inherently biased, and they're biased by the patient. So we want to know what they're feeling, you know, what's going on inside of them, because I can't possibly know how they're feeling. Vital signs need to be taken in a roundabout way based on the patient's condition. Now, this is something that we didn't really talk about during the earlier slides, so I want to mention it here. A patient that is vital should have their vital signs a patient that is stable should have their vital signs taken every 15 minutes. A patient that is unstable should have them taken every 5. So if they're good to go, everything's looking good, every 15 minutes. If they're not looking good, if you're looking real sick, real hurt, every 5 minutes. And we don't need to sit there and clutch pearls. Oh no, it's been 3.5 minutes. I'd love to take your blood pressure, but I can't. You can take them every 5 minutes or as often as necessary, as often as you see that there's a change. So if you give a patient a drug and all of a sudden they went from, I don't feel good, to, you know, passed out on the floor, we should probably take vitals. Again, you know, we'll check for a pulse and we'll make sure that they're breathing and make sure their airway is clear. But at the same time, we need to check for another set of vitals because there's been a clinical change of a major event. You got to check it. Now, if you have time to obtain vital signs on scene, it means that your patient's probably fairly okay. Now, if you are looking at the patient and you're, you know, looking at them and saying, oh, they don't look so good, the only time that we should be staying on scene to take vitals is if we're waiting on ALS, or if there is some reason that we can't immediately leave. If you're going, oh, they don't look so good, the vital signs can wait until we start transporting. We really should never delay transport on a critical patient or a patient that looks very sick, very injured, just to get a set of vitals. Because honestly, that is something that you need to develop as an ENC, is taking vitals in the back of a moving vehicle. That's just it's a necessary skill. Also, we need to consider when we use some of our tools, like a pulse oximeter. Should you apply a pulse oximeter to a patient that's having difficulty breathing? The answer, if you have it, is yes, but you should apply it to them and consider the other things that they're saying. I'm having difficulty breathing as a statement. Difficulty breathing is something that, you know, largely should be observed before reporting. Now, does that mean that a patient that is doing a good job of you know, kind of keeping how they're really feeling deep down, you know, hidden, is that a good thing or a bad thing? I mean, it means that they're, you know, really good at hiding how they're feeling. But I will say that when it comes to respirations, when it comes to breathing, as humans, we really do not do well at hiding when we don't feel like we can breathe very well. You can look for the little signs too. If someone's taking tiny gasps and just trying to hold it because it hurts to breathe, or, you know, they're just trying to get in as many lungfuls of air as they possibly can because they're really, you know, physiologically stressed. Their body is dying. Right? So I would say that if your patient is saying that they have difficulty breathing, you have an SpO2 monitor, put it on. The worst thing that it's going to do is, you know, maybe skew your opinion, but you should definitely have a formed opinion before you use that. That tool should help you confirm what you've already measured, what you've seen, what you've been able to auscultate and observe. We wouldn't really palpate difficulty breathing. That'd be weird. Let me poke you in the lungs. But what we've observed and auscultated should be backed up by the SpO2. Also, if we have a patient that does not have difficulty breathing, some of our agencies say, hey, every patient needs to have an SpO2 measured. Great. Do that, but don't base your treatment based solely off of that. Base it off of that and other information, observed or auscultated and otherwise. Cool. Now, this is where we start to get into those key factors. Consider your vital signs. Are they abnormal because of their illness or injury, or are they abnormal because of something that is not related to their illness or injury? We talked a little bit earlier about a patient with a resting heart rate that is below 60. That would be considered what? Yeah, bradycardia. Bradycardia, again, may not be an indication of an emergency for them because their heart is very well conditioned and it does not need to beat between 60 to 100 beats per minute to keep blood flowing effectively. By that same measure, some patients, they live with hypertension, tachycardia, things like that. Doesn't mean that they're necessarily healthy, but it doesn't mean that there's anything necessarily wrong. So what we need to do is we need to take our measurement, and to the best of our ability, we need to consider how they look, how they appear, and what we've measured. And with multiple sets, determine, is our baseline normal or abnormal for the patient? So in a nutshell, look at the patient, their presentation, and say, is this normal for you or is this abnormal for you? And if it's abnormal for them, does that correlate to what they're dealing with? You know what we can find on pretty much every call? The patient's in pain. Do you think that their heart rate's going to be slightly elevated? Yeah, because when we're in pain, our heart rate tends to be slightly elevated. Our blood pressure tends to be slightly elevated. Our respiratory rate tends to be slightly elevated. Our skin signs don't look great. And we're talking about real, actual pain, not, I stubbed my toe, it's a little sore. We're talking 8 out of 10, 9 out of 10, 10 out of 10. We're getting to the point where they can't even say it's a 10 out of 10. On a scale of 1 to 10, how bad is your pain? And they just come back with, it sounds like a 10 out of 10. Cool. Now, you need to be able to name all the vital signs. At the end of this, you should be able to name them all. You should be able to explain why vital signs need to be taken more than once. And it says, how much time should the EMT spend looking for a pulse when the radial pulse is absent or extremely weak? I'm going to tell you what the answer is to that right now. If the radial pulse is absent or extremely weak, you should spend no more than 10 seconds, no more than 10 seconds looking. If you can't get a radial, you can bump up to a brachial, so you can go from the wrist to the inside of the elbow. But if they're unconscious or unresponsive, don't check for a radial even to begin with. Where do you go? Straight to the neck, straight to that carotid. These are the last of the questions. How should you react when the blood pressure monitor gives a reading that is extremely different from previous readings? Well, that typically means, and a blood pressure monitor is an electronic device, it's a computer. What that would typically mean is that either you were incorrect or the patient has gotten significantly better or significantly worse. So before you say, oh, I'm such an idiot, I don't know how to take a blood pressure. Look at the patient. Do they look better? Do they look worse? A phrase you'll hear me say in class a lot is treat the patient, not the machine. Machines make mistakes, just like humans make mistakes. Consider what you're reading, consider what the computer is reading, and say, hey, do you think that computer, that monitor could have been influenced by bouncing around? It's hard to get for a blood pressure cuff to get an accurate blood pressure when it's, in a really bouncy environment. Noise doesn't affect it, but movement does. So consider that. Also, have confidence in your skills. And believe me when I say that having a blood pressure monitor or having a cardiac monitor with a blood pressure cuff attached to get a totally different result from you is demoralizing. It doesn't matter how long you've been doing this, but don't let it defeat you. Just look at it and say, okay, I must have missed something. I'm going to go back and I'm going to consider what I can go and observe, and I'm going to try to get it again. Also, it says, how can you get an accurate pulse oximeter reading on a patient with thick artificial nails? The answer is you cannot. Again, one of the reasons why that device is garbage, which is French for garbage. That's not true. All right, finally, last bit of critical thinking. Sometimes a patient's heart will have an electrical problem and beat more than 200 times per minute. Why is the pulse so weak in such a patient? I can tell you right now, the pump isn't filling all the way. It simply isn't. The pump is not able to fill at that high rate of or at that high beats per minute or BPM. The pump will not be effective. Pumps do have an effective range. 60 to 100 is healthy. It can beat slower, it can beat faster, but when we get up into 150, 160, 170, 200, that's super fast. The pump simply can't refill and empty fast enough to be effective. So that is why the pulse would be so weak. And in a patient with a true heart rate above 200 times per minute, and not something that was being, confused because of an underlying cardiac condition like atrial fibrillation. So it truly was 200 times per minute. I can tell you a couple things. Number one, you're not going to be able to count that fast. Number two, that patient is not doing well and will likely go into cardiac arrest. And number three, you are not going to be able to feel it at the radial pulse. You're going to have to check for a central pulse. So go for the carotid. All right. Here's a disclaimer. While I'm on the disclaimer screen, I'm going to say this. I know that my absence from the classroom is definitely different and making class more challenging. So that's why I'm going to be doing these videos. I want to get feedback from you. So please tell me if there's something that I didn't go into enough detail on, and I can do a supplemental or appendix video, I guess. I think supplemental is the right word. Appendix is not the right word. Sorry, I'm tired. But I'm here to make sure that you guys are well supported and that you guys feel that you are in a position to be successful in this class. I will return. I'm not going to be gone for more than the allotted time that I was given or that I requested. I'm very fortunate. My wife is healthy. My son is healthy. We're very fortunate. And I want this time to be, fruitful for all of my students. I want you to learn. I want you to feel like you're getting everything that you need to be successful. And that's what the goal of these videos are. In the meantime, thank you very much for all of your hard work. Thank you very much for all of your feedback. Please continue to let me know how things are going, if there are anything that you may have questions on. And aside from that, thank you very much for being in my class, and can't wait to return to see all of you guys. So take it easy. We'll see you soon. Bye-bye.